Okay. Well, welcome everybody to this tipsRO webinar on novel patient-focused initiatives in radiation oncology. This morning we have two very interesting presentations, all related obviously to patient-focused activities, but from very different perspectives. So our two speakers this morning will be Dr. Luca Tagliaferri, who currently works at the Gemelli Arndt Center of the Gemelli University Hospital in Rome. And he's addressing his clinical and research interests, especially on interventional and metabolic radiotherapy, medical software developments in the field of research, teaching and patients' care represent additional areas of scientific activity. He's currently head of the Interventional Radiotherapy Unit and is involved in multiple HDCR congresses and activities. And he became the chair of the Head and Neck and Skin JEC-HDCR Working Group in 2018. He's a member of JEC-HDCR and HDCR Guidelines Committee, and he will be talking about art and digital technologies to support resilience during the oncological journey, the Art for Art project. Our second speaker is Sophie Busbifier, who's been working as a radiation therapist for 15 years at the Léon Barrade Center in Lyon in France. After conducting research on head and neck cancer patients' positioning for radiotherapy, she completed her education with a university degree in clinical research. In 2019, she obtained 2 national grants for clinical trials. And since 2021, she has been working on a new research project on upright radiotherapy and is dedicated full-time to research, with a large part of this focused on the upright radiotherapy project. She's also involved in 3 other clinical trials as a principal investigator or associate, and in the development of research led by radiation therapists. And her paper today is Upright Patient Positioning for Pelvic Radiotherapy Treatments. So you're both very welcome, as indeed are all our participants. And I will hand you over to Luca now to give his presentation. Thank you.
Thank
sorry,
you.
I'd just like to say, if anybody has questions, maybe you would put them into the chat and we can address them at the end of the session. Sorry, thank you very much.
So I would like to thank the chair for the kind introduction and for the opportunity to present our experience regarding the Art for Art project. So we know that especially in the last decades, we have seen technological innovation in the field of radiotherapy. But it is important to highlight, it is important to stress that we can't forget that we need to consider always in our clinical practice another dimension, the patient dimension. Because we know that we can synthesize our daily practice as a present delivery. And the present delivery is, of course, the local control, the disease control, and the quality of life. And of course, in this procedure, in this delivery, it is very, very important, the working multidisciplinary team that we like to call interdisciplinary team in order to stress the interaction that we need among the physician, the RTTs, the nurses, and the psychologists. And for this reason, we would like to offer for this webinar different point of view. Because on the basis of our project, on the basis of our Art for Art project, there is a very strong interaction among RTTs, nurses, psychologists, and radiation oncologists. So we will discuss regarding the physician point of view, but later also the RTTs point of view. And I'll introduce Patrizia Cornacchione from our team, and then the psychologist's point of view, discussing this topic with Loredana Di Napoli. So, starting with the physician point of view. Of course, we know that after diagnosis, the patient experiences an existential earthquake. And this existential earthquake can be correlated with a fear to death, fear to dying, but also fear for the impossibility to plan the present and the impossibility, especially the impossibility to plan the future. And this fear can impact with the psychological aspect of the patient, especially with the stress mechanism. And we know that the stress mechanisms can impact with the biochemical environment, especially considering the cortisol, and the biochemical environment can impact with the prognosis of the patient, because can impact with the tumor growth and the tumor progression. Of course, in order to increase the relationship with the patient between health operator and the patient, the gesture can be at the base of this contact. And the gesture can be providing with welcoming, caring, and guiding. And in the past, we can find in a very old hospital, such as Santo Spirito in Saxia in Rome, that the art was one of the first tools for delivering relief when the technology was not so enough for cure the patient. And several papers reported that the arts, the patient seeing the arts in some aspect can impact with the stress mechanism, reducing the level of cortisol, and indirectly can improve the prognosis of the patient. And for this reason, why not? Why not to paint with the Colosseum our treatment room, or to paint with a Roman vial another treatment room, Villa Adriana? Villa Adriana is a vial, a Roman vial very close to Rome. But it is not enough. On the base of our Art for Art project, Art for Art is art for advanced radiation therapy. So the art involved in the cure process. And on the basis of this project, there is also a platform, a special lab, connected with the digital radiotherapy ecosystem and connected with a machine learning that can profile the patient. So using this app, the patient waiting the treatment, or you will see during the treatment, can select some art opportunities like music, like cinema, like photography, like monuments. And we know that this kind of app, also if we can introduce in the app some aspect for monitoring the patient, can impact the clinical practice, can impact the prognosis of the patient, can impact the quality of life, and can impact also the hospitalization of the patient and the access in an emergency room. But based on the profiling tool of this app, we can personalize also the treatment environment. For example, on the right, you can see the interventional radiotherapy room. And the patient can select, or we can propose based on profiling a special environment, considering movie, music, voice, light, and also aroma. So the patients can experience the interventional radiotherapy procedure in a special environment, in personalized environment. But of course, our thing is also for children, for our little patient. And why not to paint the treatment room dedicated to children with an Aquarius, and inside the Aquarius, a submarine. And why not? We can't tell a special story to the little children, to the little patient, in order to live the treatment in a fantastic environment. For example, the little patient can become the pilot of submarine. And using this kind of approach, using the art for art approach, we can report a low rate of sedation, because the patient is less stressed and can be alone in the treatment room without anesthesia. But of course, it is important also to speak about the environment outside the treatment room. And why not to install in this environment a vertical garden, or install a large wide screen in order to offer to the patient some opportunity also when the patient is waiting for the treatment. But it's important also to change also our approach, not only the environment or some proposal. For example, it is important to change the vocabulary. Why we use a negative word? For example, waiting. Waiting is a negative word. Why we use a waiting room? So we like to use a welcoming room in order to stress that the patient is welcomed in our center. And speaking about also chemotherapy, we have a special service for performing chemotherapy concomitant to radiochemotherapy. And why it is not possible? So why don't propose to the patient to receive chemotherapy in an immersive room, and for example in a nature environment, or to perform chemotherapy during a private virtual tour in Vatican Museum, or propose to our little patient to wait for the treatment in an immersive cartoon in order to reduce the stress of our little child, little patient. But it is important to work, and it is important to think also to the multidisciplinary team. And for this reason, in our phone, we have a special broadcast WhatsApp service. And every week, we receive a shared gratitude message from our patient. If the patient sent to me a message for gratitude, I share this message to all members of the working team, RTT, psychologists, nurses, and of course, radiation oncologists. But based on our project, we like to report also that there is a network in Italy, in our country. So other centers accept to follow this project accept to follow this vision for approaching the patient. And for example, Mater Art in Sardinia, or Mulli Art in Apulia, or Molise, Gemelli Molise Art in Molise, or another center in Rome, Gemelli Isola Art. Finally, the project received the endorsement of Italian Ministry of Culture. Now, I would like to invite Patrizia to share the RTT point of view regarding this project. Please, Patrizia.
Okay, thank you. Thank you all for this invitation. Thank you, Dr. Tagliaferri, to give me this possibility to underline, to explain the point of view of the RTTs. The first slide, yes. Maybe the question is why is important to underline this relationship between RTTs and patients. Probably we all know about the radiation therapy patient pathway today, but if we think about explaining to other people the role of RTTs, the first thing we often say is the RTT is the professional who is near to the patient every day during the procedures and during all treatments pathway. Effectively, he is the professional who accompany the patient on this journey and who establish and offer deep relationship with patient. So it's most important to underline that during the training of RTTs, we have three important tasks that is necessary to increase during the our professional experience. The first important is the technical skills because it's specific to the professional role, but is most important also to acquire other skills in two important scenarios. The first is a good skill about the relationship and the communication, to have a good communication with the patient, but also, for example, with the caregiver that every day we have in our areas together the patients, and in addition to acquire specific competencies about the good management about the radiotherapy service to increase the quality and safety during the procedures, during the pathway. And with these last two aspects in mind, I would like to take a few minutes to highlight two important scenarios that is it possible to develop for our rule, please. As also you can read in many publications, but you see in this slide just one example. The RTT is taking role also in patient engagement pathway, and then also in patient education during the pathway. So not only technical skills, but also other ability that we can acquire, please. In our experience, two areas where a lot of work is being done is the figures of the RTT care manager and the patient education. Who is the care manager? In general, is it possible we know that these figures, the care manager, is probably to see in other contexts, for example, with other professionals. In general, we have many nurses that in our service have the role of care manager, but is possible to increase difference ability also for RTT to acquire these specific characteristics for this role. And why is important? Because the care manager is a figure who accompanies the patient and educates them in the patient in the pathway of digitalization of care. And there are many study protocols in which symptom monitoring during and after treatment takes on importance, and the RTTs is the phases we have realized is an important figures because can educate and reassure the patient on what to do while also giving daily availability of support for any needs.
I don't
second
mean
aspect,
to interrupt you, Patrice, but we are running very short on time. So I didn't want to interrupt you, but if you could just be careful on the time, because I know you also have a psychologist coming in.
Perfect, thank you. Okay. A second aspect, the most important, is the multidisciplinarity to optimize humanization pathway. This study is an example where a team with many professionals collaborated to understand how to improve the needs of patients. In this case, patients undergoing interventional radiotherapy with a gynecological cancer to understand how to decrease the anxiety. In this slide, we can see how it's important to have a multidisciplinary team with also the presence of the RTT, for example. And the result underline the importance of having a comfortable environment and the importance of the language used, often simplifying even a word or description can decrease anxiety and fear before the procedures. And this result were indeed demonstrated with this second publication currently in print, the importance of patient management in team working synergically. In conclusion, using the motto HDCR 2024 to increasingly improve pathway according to humanity and quality, we can acquire new skills to fill other gaps and better listen to the patient's needs. Thank you.
And
now the psychologist point of view, please, Loredana.
Okay, so thank you to you all for this invitation. It's very important for me. I have described here the characteristics, the psychological characteristics of patients that Luca summarized very well in the emotional and existential earthquake. So each patient has a specific requirement during radiotherapy, and radiotherapy is important in each phase of the cure. So it's very important for us to know that anxiety and depression is very, very common, about 30% in radiotherapy patients. So in our department, we have built this psychological service for adult patients that arrive to me in very, very different ways, with self-referral, by clinical observation, by means of radiation oncologists and radiation therapists, by nurses. And we have created an automatic pre-organized session schedule for head and neck cancer patients and primary brain tumor patients, rectal and anal cancer. This is the distribution of patients in my room, in the psychologist room. And to date, since the 1st of January, we have performed about 1,000 psychological services with 300 patients distributed in different pathologies. And I wanted to focus the attention on these publications from a psychological point of view, because we focus on the quality of treatment with the immobilization device. So we utilized evidence-based psychotherapeutic approach to improve the anxiety and the claustrophobia sometimes of these patients. We have personalized taken in charge in brain tumor patients. We have focused attentions of the modesty of breast cancer patients, and all these data have been presented recently at the International Congress of Psycho-Oncologists, just to focus what the women want during their treatment. And I hope you'll read it very soon, this paper. And then Patrizia told us about very well of the importance of the interdisciplinary taken in charge in gynecological cancer patients. And we want to focus on the resilience also by means of the art such as Luca described before, because we have found that in some cancer patients, resilience is very important, not only for the treatment itself, but also for surviving of cancer patients. But together with resilience, we have to focus also on the positive aspect of trauma of cancer. For example, the post-traumatic role in oncological patients, which is very important to give patients the possibility to go on and to also bounce back to the phase of their normal life before trauma. And just to conclude my interventions, we have also published this paper a couple of years ago about the importance of the feedback of the patients in our department. And the patients give us a smile if they are happy and comfortable. They feel that we are professionals. And these feedbacks are monthly received in our department, and we want to use them to improve the quality of our service, to give the patients the opportunity to feel engaged also during the treatment and feel welcome in our department.
So, in conclusion, it is important to receive also the feedback from the patient weekly, daily, monthly, in order to know if our approach could give benefit for the patient. We started from this slide. Our work is a present delivery. It is important the working team in order to deliver this present. It is important technology, and we know that the modern technology is image-guided, artificial intelligence-guided radiotherapy, omic-guided radiotherapy. But it is important to welcome the patient with an embrace. And in embrace, we need two arms, the arms of technology, but also the arms of relationship, the arms of humanity. And in this way, we can offer to our patient a good patient-centric approach, a good humanist-guided radiotherapy. Thank you very much for your attention.
Thank you very much to the three of you. It was really impressive. And having visited Gemelli, I know what a beautiful, welcoming atmosphere it is. I think we have time for one question. If any of the participants have a question, there is one in the chat box, and it's from Prakash, who asks what material you provide for patient education. I'm not sure if one of you would like to take that.
Thank you very much for this question, because we discussed it several times regarding the best tool for educate the patient. And we have several opportunities. Of course, we have some booklet with the FAQ, frequently asked question. We have collected from many patients some question, and we have tried to answer to this question. We collected the question and the answer, and we offer a personalized booklet for our patient. This is the first tool. The second tool is a movie. We recorded some movie explained the patient our vision, our approach, and also some procedure, especially for interventional radiotherapy and brachytherapy. And the third tool is the app. Using the app, we can profiling, as I have already told the patient. In this way, we can offer a personalized educational for each patient in order to give them the best opportunity in order to reduce the stress, in order to live the treatment period in the best way.
Thank you very much. I was very interested in your use of changing terminology, like the welcoming room rather than a waiting room. It's really positive. And have you included something like that in your patient surveys? Does that make them feel less threatened, say, for instance, when they come into the department?
Exactly. Another word that we are changing is also brachytherapy with interventional radiotherapy, because brachytherapy is unknown. And usually the people, if don't know something, have a fear of this thing. So interventional radiotherapy is more useful in order to explain the technique, interventional and radiotherapy. And we have found the benefit also in change this word in our clinical practice.
And I have one other, don't take it negatively, I'm just really interested, where patients can select their own music, say, or their own film. Does that, say, in the very long term, have an emotional impact? Say, will patients 2 years later not want to hear that piece of music again? That sort of association, and you want to put it behind you and move on. Have you come across anything like that?
Exactly. I don't know if Loredana would like to answer to this question involving also psychological aspect.
Yes, this may happen. I have some patients that don't wear the same dress that they are going to wear during treatment, so it's the same. Perhaps they listen to this music during treatment and then they will not listen anymore, but it's not the same experience for each patient. But yes, it will happen sometimes.
Thank you very much. Anyway, it's just a fabulous environment, I'm sure, for the staff as well as patients. It's wonderful to work in. But we'd better move on to Sophie, if you wouldn't mind taking over now for your presentation again, which is really fascinating. Having worked on radiotherapy with patients sitting up a century ago, I'm really interested in your project. Thank you.
Thank you, Mary. I will share my screen.
Yeah, it's perfect.
Good afternoon, everyone. Thank you for the introduction and thank you for giving me the opportunity to share my work. I will present you my article on the upright positioning for pelvic cancer patients, which was published in November 2022 in the journal tipsRO. First, as you know, radiation therapy treatments are performed with patients in supine position. Our patients were set up with immobilization devices designed for this position, and the treatment is delivered with a huge gantry rotating around them. However, some publications show the upright position may be beneficial for the patients and their treatments. Indeed, it has been shown that respiratory motion in craniocaudal direction is reduced in upright position compared to the supine position. Moreover, the lung volume is significantly higher in standing and sitting position than in supine position. So this data suggests that for lung irradiation, the upright position may be associated with a lower mean lung dose. Regarding pelvic tumors, it has been demonstrated that first, the bladder is more elongated in the anteroposterior direction in upright position compared to supine position. In addition, the distance between the sacrum and the bladder is reduced in upright position compared to supine position. And the changes in bladder filling don't modify the prostate position significantly. So if we summarize and try to analyze this data, the bladder may avoid the small bowel to fall within the pelvic area in upright position, and the constraints for the patient to fill the bladder in the same way may be less important. Finally, Macarol et al., with testing upright position with head and neck cancer patients, showed that patients were more comfortable, physically comfortable in upright position at the back level compared to the supine position. In this context, in March 2021, the EV positioning system was installed in Lyon, in my department, by Leo Consequia team, and a research program was developed. This program includes 4 main steps. First, the development of methods to set up the patient and immobilization devices for the upright position. Second, the assessment of patient positioning and immobilization accuracy. Third, the study with patients and radiation therapists on their experience about upright position. Finally, the evaluation of organs' position and motion. In this first study published in tipsRO journal, we had 3 objectives. First, to evaluate the upright position and immobilization accuracy based on the inter- and intra-fraction deviations. Second, we assess the setup duration and durations of first positioning, repositioning, and uninstallation steps. Third, we compared the patient physical comfort in upright and in supine position. In this study, adult patients with a curative pelvic radiotherapy treated on an electrical linear accelerator or tomotherapy unit were included. Regarding the upright positioner, here you have a picture of the device, with in 1 the backrest, the seat pan in 2, the chin rest in 3, the heel stop in 4, and finally in 5 the armrest. The whole device is on a platform which can rotate with an helical movement. In addition of the positioning system, there is an optical guidance and tracking system developed by Leo Consequia with 2 20-megapixel high-resolution optical camera, which are set at 90 degrees apart from each other. A software completes the device and allows to acquire reference images, compare the live image in green and the reference image in pink, and quantify the deviations between both images. Regarding the patient workflow, the patients included were treated in supine position with a head cushion, a knee cushion, and a minimum of 3 tattoos. This patient had 3 additional appointments. At the first appointment, we set up the patient on the upright positioner, record the position of the different parts of the device, and acquire the optical reference images. During the second and the third appointment, patients were repositioned on the upright positioner, and the treatment session was simulated with several helical movements during 20 minutes. To set up a patient on the upright positioner, the backrest was positioned with an angulation at 5 degrees backward and the seat pan at 50 degrees to have a position close to the standing position. A vacuum cushion was set with more beads on both sides and at the lumbar curve. Then the patient was invited to get in the device and stay in standing position with legs against the vacuum cushion. The seat height was adjusted according to the patient leg's length. And the shin rest was moved closer to the patient legs. Then the patient could sit up on the vacuum cushion, and the shin rest and heel stop were adjusted according to the patient. Finally, head cushion, arm support, and belt were positioned, and the vacuum cushion was modeled. The data collection included patient characteristics with age, patient height, but also patient setup characteristics with seat height, shin rest position, and heel stop position. First positioning, repositioning, and uninstallation durations were collected. Interfraction and intrafraction shifts were also collected, and the patient satisfaction regarding their physical comfort, but also their satisfaction, was gathered on a specific questionnaire. Between October 2021 and June 2022, 8 men and 8 women were set up. The age range of the patients were between 35 and 81 years. 3 patients had postoperative radiotherapy, 7 had chemoradiotherapy, and 7 had exclusive radiotherapy. Regarding surgical history, in addition of their cancer disease, 3 patients have had knee surgery, including 1 patient with a knee prosthesis. No large weight changes were observed between the first positioning in upright position and the last appointment. Now, if we look at the patient setup time, in average, 40.4 minutes was needed to set up a patient at the first time with 1 radiation therapist and 5 minutes with 2 RTTs. The repositioning step took in average 4.9 minutes with 1 RTT and 2.9 minutes with 2 RTTs. 2.5 minutes were needed to get out the device with 1 RTT and 0.6 minutes with 2 RTTs. All these results were statistically different with smallest duration with 2 RTTs. Based on 14 patients with 2 repositioning setups and 2 patients with 1 repositioning setup, the interfraction shift mean were minus 0.5 mm in right-left direction, minus 0.4 mm in anteroposterior direction, and minus 0.9 mm in craniocaudal direction. For 1 patient, at the second repositioning, large shifts were observed in right, left, and craniocaudal direction. Minimum 90% of the values collected were inferior or equal to 3 mm, as we can see on the diagram with the purple bar. Regarding intrafraction accuracy now, after 20 minutes on the upright positioning system, the shifts mean were 0, 0.2, and 0 in right, left, anteroposterior, and craniocaudal direction, respectively. More than 80% of the shifts collected during the treatment simulated were smaller than 1 mm. On 15 patients who filled the questionnaire, 13 were at least comfortable in upright position and 11 in supine position, with 1 patient who was in pain in supine position. This result concerns the global physical comfort. And if we look at the physical comfort of the different parts of the body and the questions on the patient satisfaction, the patients were at least as comfortable as satisfied in the upright position and sometimes even better than in supine position. What we can say about these results? The first positioning and the repositioning time were reasonable with 1 RTT and shorter with 2 RTTs. The first positioning, including the definition of the patient and the chair position, corresponds to the actions which are typically done in the CT scan room. In upright position, a vacuum cushion was modeled for all patients, contributing probably the patient's physical comfort and some repositioning and stability. This step significantly decreased with the presence of 2 RTTs, which is completely unstable. Confidence and expertise can also contribute to the time saving. To our knowledge, there are no data in the literature regarding the first positioning duration in supine position for pelvic treatment. But Mannerberg et al. Reported a mean repositioning time in supine position for prostate treatment of 2 minutes, 50 seconds, which is consistent with our results. In upright position, the interfraction shifts mean were below 1 millimeter, allowing an accurate repositioning, and these results were obtained without patient alignment with laser, without skin marks, and without RTTs to move the patient. Because SGRT is now widely used to quantify setup reproducibility and immobilization in radiotherapy, we can find in the literature several studies showing a good correlation between SGRT with a PED, so based on bony registration in supine position. Putting together this data and our results, it looks like upright positioning definitely warrants further considerations. The intrafraction motion was within the 1 millimeter for more than 90% of the patient images in a 20 minutes time frame. So the patient stability was excellent in this position. If we consider a treatment time only for the beam for VMAT irradiation, for example, in supine position is within 3 minutes, the upright position should allow a safe treatment delivery. Regarding patient satisfaction and patient comfort, the results were promising with patients at least as comfortable and as satisfied in the upright position, and sometimes even better than in supine position. Of course, some improvements are possible, in particular in the design of the belt and the head cushion. Our study has few limitations. First, the sample included only 16 patients with a maximum of 3 setups. Secondly, the inter and intrafraction assessments were based on the skin match with optical images. This doesn't guarantee that internal organs and tumors will also be positioned and repositioned adequately. Thirdly, we only dealt in patients with pelvic tumors. In conclusion, the results of this first study on pelvic cancer patients set up in upright position on the Leo Cancer Care chair is promising and open a potential new direction for radiotherapy treatments. Considering the limitations of this study, patient positioning assessments with head and neck cancer patients and thoracic cancer patients are ongoing. And the next steps include a work on the patient position for over-treatment localizations globally, but also a clinical trial to compare the organs' position and their motion and those distributions between upright and supine position. But for this, the vertical CT is necessary, but it is not yet FDA CE mark approval. Finally, we are also working on protocol to compare the patient experience and the RTT's experience about upright position, and more specifically, their perceptions, their sensations, because the relationship between patients and RTTs can be modified with this position. Thank you for your attention, and I will be happy to answer your question.
Thank you very much, Sophie. It's most interesting, and I think it's really good to see how RTs are leading some of these researches in things that are very specifically part of their role. There is one question in the chat box, and that's related to children. And do you think that having this would be beneficial to children, or would there be specific issues? I mean, obviously it's designed for an adult, but you wonder for a smaller child how the positioning might work.
So, of course, children are very interesting for us on this work, and it's an additional challenge in terms of point of view about patient positioning, because we need to develop new immobilization devices, but it could be definitely beneficial for this little patients, because it's a game. I tried to set up my son on this chair, and for him it was a game to be able to see the environment and to discuss with me in front of him. So I think it's a huge benefit, and potentially it's another benefit, that clinical benefit in terms of organs position and motion.
Yeah, and I agree. I like the concept that when patients are lying supine on a table and you're looking down at them, you're creating a different relationship rather than if you're actually looking straight at them and you're at more or less eye level. And I think you mentioned that too, that satisfaction from a patient point of view, that they discuss more with you or they can talk. It's a nicer relationship.
Yes. But to study this part, we need definitely the CT scan, because that changes obviously the environment. Because now we have only a chair, so of course a chair is not an anxious environment. But with the CT scan, with a fixed beam, maybe it could be changed.
And in the longer term, I mean, I was interested, I presume for planning, you're still doing your conventional CT positioning and you're planning based on that. And how do you then translate that into the actual treatment position and the verification? Because it must be different, your organs will be in different positions.
So the idea is to compare CT scan acquisition with a patient in supine position with CT scan acquired with patient in upright position. And to compare, of course, organ at risk, but also a tumor position, but shape and motion.
And of course, once you can acquire an image with a vertical CT, then your planning becomes much more straightforward. But as you say, that hasn't actually arrived yet, I think you were saying. So that's the next step. Okay.
Exactly.
And the other thing, oh, sorry, there's another question. I can go to this one here. You did also mention that there was no obvious weight loss, but Sophia has asked, what about possible weight loss during treatment? We know patients often lose weight maybe 2/3 of the way through, but you didn't notice that.
No, not for this patient cohort, but of course some of our patients lost weight, so we need to know what would be the consequences, but in the future.
In the future, yeah. And it's interesting because when I was working and we used a chair, as I say, a very long time ago, we mostly used it for thoracic patients who were having breathing difficulties and where lying down was extremely difficult for them. So do you have any plans to actually look at maybe thoracic irradiation, lungs?
So yes, of course. So the idea is to study the beneficial, the benefit for different patient cohorts according to the treatment locations that include head and neck cancer patients, thoracic, so lung cancer patients, but also breast cancer patients, and pelvic with cervix and prostate cancer patients. Yes.
Yeah, interesting breast. I find it hard to visualize breast, but then that's something new. Just in terms of the participants, I think these have been two really fascinating presentations and so innovative. Does anybody have any other examples, maybe from their own practice, of things that they've done that has changed how we relate to patients or how we manage patients in our department? I love the positive approach, but does anybody have any other things they'd share with us or any questions? Very quiet group. Well, I can ask a question, Sophie, on a very different topic. I wrote down the times I was really very interested in when you talked about the difference between having one or two RTs in a treatment room when you're managing patients. And I was just fascinated to see the figures, because we've always said that it's a real problem for a single RT in a treatment room trying to set patients up, and that it is really not ideal practice. So I was really fascinated that you had actually timed it. I think it gives, it maybe gives us a little more armor, to a little more ammunition for us to use in terms of staffing levels and good practice. But so.
The problem is linked to the research. At the beginning of this project, I was alone to have time for this research.
Yeah.
But I know that in practice, it's not the current practice in France. We cannot treat a patient alone, and I think it's the same thing for the majority of the countries. So it was not the real life, and I needed to involve a second radiation therapist, and it's why I have all these figures and these results.
Well, I think they're very useful, because particularly with a couple of projects running at the minute on staffing and workload, and so many centres and countries are having recruitment difficulties and staff shortages. So for me personally, it's great to have actual data. So secondary, I'm very grateful. Okay. Well, I suppose it's out of only to end, if nobody else has any other questions. I think we had really excellent presentations on both, obviously, the technical, physical feelings of patients when they could maybe sit rather than lie. I was interested that they're more standing than sitting, which of course with pelvic patients is more appropriate, but also the whole welcoming environment when you actually put nicer things on the wall, or you have the immersive rooms, is so beneficial. We actually had a meeting yesterday with a group of patients to see how you could make the environment more friendly, how you could make the whole process more welcoming to patients and more comfortable. So I think these two presentations absolutely consolidated all of the discussion we had yesterday, and certainly in terms of welcoming rather than waiting rooms, I think that's something that in many centres they could change, because obviously to do something like Gemelli takes a lot of resources, but there are also very small things that we could take from it in less well-resourced departments where you could make those changes, and they would be very beneficial. So only to thank you all very much, and also to say that everybody will be informed when the next webinar is happening, and that'll be on the tipsRO science homepage in a couple of weeks. And I'm sure it'll be excellent, but probably difficult to top the two we've heard today. So thank you very much indeed, everyone. Thank you. Bye.
Thank you.
Thank you.